Hi, this is Bob Harrington from Stanford University on Medscape Cardiology and theheart.org. We're really looking forward to our conference in December, going back to the heart of cardiology. We have a great lineup over the few days of the conference. And one of the sessions is going to focus on unusual or rare diseases that clinicians practicing cardiovascular medicine, primary care may see. Today, I'm really pleased to be joined by an expert in the field of preventive cardiology to talk about homozygous FH, HoFH. With me today is Dr. Seth Baum. Seth is the CEO of XL Medical Clinical Trials, and Seth is also a past president of the American Society of Preventive Cardiology. Seth, thanks for joining us here on Medscape Cardiology today.
Thank you very much. It's great to be here.
We're really looking forward to this session. There's some terrific topics that are going to be covered. The sort of thing that when you see it in clinic, you say, maybe I should know something about that and look it up. So we're fortunate today as we focus on FH and particularly HoFH, homozygous FH, that we have you to help guide us through the conversation. Seth, let's do what I've been implying, that HoFH is a subset of FH. So maybe you can set the stage and talk to the audience a bit about what is FH, what are sort of the issues around it from a cardiovascular health perspective, and then maybe dive specifically into HoFH, and we'll get into things like the prevalence, consequence, et cetera, as we go.
I think that's great. It's great to start with FH, the overarching FH or familial hypercholesterolemia, and then move into HoFH so that people don't get the misapprehension that HoFH is which is ultra rare, is the only thing we need to be concerned about. We do need to be concerned about it, but FH, again, overarching disorder, is extremely common. So FH, or familial hypercholesterolemia, is a genetic disorder that has a prevalence of probably in the order of 1 in 200, 1 in 225, which is just not rare. When, way back when we were in medical school, we all thought of FH as a very, very rare disorder. We'd never see it in our lives. And we've learned quite a lot over the past couple of decades. We've identified with regard to the LDL receptor mutation, for example, over 2,000 mutations. So, there's a lot that's been learned. The reason it's so important to understand the prevalence of FH and to consider it in our practices is if you think about it, if it's 1 in 200, 1 in 225, somewhere around there, that means every single practice in the United States has patients with FH in it. And, probably 90% of those patients are unrecognized. And so what does that lead to? Well, if you have somebody with a genetic LDL disorder, and we know that LDL causes vascular disease, it's no longer the LDL hypothesis, it's the LDL fact now. So if we know that, and these people have very high LDLs and they have premature heart disease, we're missing opportunities to prevent events. And we're missing opportunities to prevent events in the patients we're seeing, but also in their relatives, their kids, for example. So we need to think about FH. We need to have that diagnosis on the tip of our diagnostic tongues, if you will. And then we need to go even further. We need to make the diagnosis. We need to cascade screen, which means look at first degree relatives to see whether or not they also have FH. And the way we can identify FH in the first place is very high LDL. So in adults, let's say we look for LDLs over 190, a family history of premature heart disease, or premature heart disease in the index case, in the person we're looking at in clinic. Occasionally, it's not as common as we used to think. We'll find tendon xanthomas in these people, or we'll find a corneal arcus in somebody under the age of 45. That's pathognomonic for FH. So these are things on physical exam we should look for the Achilles tendon is a prime place to look. And so when we're feeling the pedal pulses, for example, we should reach around and just get accustomed to feeling the Achilles tendon. When you feel a thickening of the Achilles tendon, you got to think, ooh, maybe this is somebody with FH. And then we need to treat them very aggressively from an LDL reduction standpoint. So this is a very, very important place to begin, is thinking just about FH, or heterozygous FH, the overarching disorder.
Yeah, some really, really good clinical tips there, including number one, I like the physical exam commentary, because it's actually what I do. Is I'm feeling as an old interventional cardiologist, I'm always feeling the distal pulses,
Right.
and reaching around to feel the Achilles tendon. That's a great clinical pearl. I also like the focus on cascade screening. Oftentimes, people will ask you, should my kids be screened? Absolutely, so
Mm-hmm.
that we can understand this. But now let's hone in on homozygous FH, which, as you've indicated, is a lot less common than the overarching FH. Let's talk first of all, what is the prevalence of homozygous FH? And given we know what the consequence of FH is, which is premature atherosclerotic disease, I'm assuming we're going to talk about very premature atherosclerotic disease.
Yeah, so the prevalence of HoFH, or homozygous FH, is about 1 in 250,000. We used to think it was about 1 in a million, but 1 in 250,000, maybe even a little more common than that. But it's still ultra rare. There's no way around that. It's an ultra rare disorder. That would be about 1,300 people in America would have homozygous FH. It is, as you say, a disorder of extremely high LDL cholesterol, and at birth, these children have extraordinarily high LDL cholesterol. In utero, these kids have extremely high LDL cholesterol. So they're making plaque. They're starting that plaque process early, very early on, even in utero, perhaps. So and frankly, HeFH too, just to go back to that for a second, they also have very high LDL levels in utero. So they're basically bathing in LDL from conception on, and this is part of the issue with why they get such premature heart disease. So back to HoFH. So very, very rare, ultra rare, very high LDL levels. And what this does is puts children at risk for things like sudden cardiac death. There are children who've died of infarcts under the age of 5 years old. So this can be a terrible disorder, one that we really have to be on the lookout for. Certainly, if you have patients who have heterozygous FH, you have to start thinking, well, their kids, might be patients with homozygous FH. So we have to pay attention to that. Ways to recognize that in children. Well, first of all, if you have patients with heterozygous FH, their kids should have a cholesterol checked by the age of 2. And certainly, all kids should have cholesterol checked by the time they're 11 or 12. And that's a pretty, established guideline. So if you identify a child with an extremely high LDL at that young age, obviously we need to pay attention. Things like apheresis, lipoprotein apheresis, we typically don't do until a child is 5 years or older. But there are certain, although diet is unfortunately not extraordinarily helpful here, you still want to avoid saturated fats. Obviously, you want to do everything you can to minimize the risk of elevating cholesterol. And then, depending upon the age of the child that you're dealing with, there are now clinical trials available. There are some drugs available for pediatric HoFH patients. So, we have statins, obviously. We have a lot of tools available to try to mitigate risk in this patient population, but we can't do anything if we don't identify the disorder in the first place. That's
Yeah, so
really the
that
key.
seems to be the key step. And let me ask, we talked a few minutes ago on the adult patient feeling the Achilles, et cetera. Any diagnostic tips for pediatricians or family docs out there who might be seeing infants with HoFH?
Yeah, so if you see early xanthoma, and specifically interdigital and and even more specifically between the thumb and the first finger. If you see a xanthoma there, that's pathognomonic for homozygous FH. So we should notice, we should pay attention to that. I saw a child recently who had interdigital xanthomas, and also between the thumb and the forefinger, the first finger, and in fact, she did have homozygous FH. So pay attention to that. I think if you see xanthomas at in any child, you should think HoFH or cytosterolemia. Actually, keep that in the back of your
Right.
mind as well.
Another unusual disease.
Another unusual disease, which we can talk about another time.
Yeah.
But keep that in the back of your mind as well. Listen to the heart. If you hear a murmur that could be consistent with aortic stenosis or supravalvular aortic stenosis, that's pathognomonic for homozygous FH, supravalvular aortic stenosis. So pay attention to that as well. The corneal arcus is typically not there at this age. One other thing to think about: if you do identify someone who you think might have homozygous FH, a child, and you're considering imaging, an echo, of course, is very important, because you can see, the valvular disease or supravalvular disease. But looking at the coronaries, you don't go to a calcium score. You go to a coronary CT angiogram, because these children have not yet laid down calcium. So they'll have soft plaque without calcium. And to understand the burden of disease, you really do have to do a CT coronary angiogram on them. So think about that as well. And then when you're looking at them or evaluating them and speaking to their parents, ask them questions like, is your child able to run around like other children? Do you notice the child getting, just stopping or looking short of breath or whatever, because this really is an issue, premature heart disease in these kids, and sudden death is not unheard of. So we have to be very, very careful.
Yeah, I mean, it really does sound as though the rapid progression of coronary disease, you certainly don't often think of a toddler, if you will, with myocardial ischemia, but I suppose
Right.
it has to be in your differential. Let's talk a little bit about the relationship between LDL and bad outcomes in kids that you identify with HoFH. FH. I think of sort of, going back to the WASCOP days, this nice linear relationship that we have between lowering of LDL and clinical benefit. Once you start seeing LDLs 3, 4, 500, do those relationships still hold? And I'm asking because are statins worth it? I mean, can you get an effect of statins and get a benefit as you begin to think about more aggressive therapies like apheresis?
Yeah, so I think so. A couple of things. One, there is definitely that relationship with reducing LDL and reducing event rates. The LDLs in some of these kids are 700, 800, and there's a long way to go to get to a good place. We always start with the statins, and then we move on to combination therapy, ezetimibe and other drugs. As I mentioned, in certain age groups, for example, 12 and up, evinacumab is a new agent for homozygous FH. PCSK9 inhibitors now approved for children in homozygous FH, and of course there's apheresis. My experience has been that you need a combination. You need to get everything. There are different mutations that cause FH, and some of them have a greater impact on the LDL receptor than others. So the LDL receptor mutations, you can have a null mutation, which means that there's less than 2% activity of the LDL receptor, or you can have a mutation that's between the 2 and 25%. Now, the one that's less than 2, you're really going to have super high LDLs, and you're also going to have less of an effect of drugs on reducing LDL, because the drugs that we use typically work by taking advantage of the LDL receptor. Other than evinacumab, actually, which works through other receptors and sort of de-repressing endothelial lipase. But the point is you're going to need many drugs to treat this disorder, and you should really be as aggressive as possible. And I think identify a clinical research site in your area that may be doing a study on homozygous FH. There are still studies going on with homozygous FH, and also an apheresis site. So these are the ways that I think we should aggressively pursue reducing risk in this patient population.
So an unusual disorder, some key things to be thinking about if you're seeing either a family or a young patient. Be very aggressive with therapies. Let's talk about some of the things that might be in the distant or maybe even not so distant future. Genetic therapies, CRISPR therapies.
Yeah.
Where's the field going?
Yeah, well, I think we're all hoping that it's going in that direction. At present, we don't have anything to my knowledge in advanced in development, if you will, for genetic or CRISPR therapies. But we all think that that's where it will go. It would be really nice to cure this disorder down the road, and that is the hope. And I, like you, I do believe that we will end up there. I don't see it in the near term, though. I don't
Not
see
in the
it.
near term. So the key thing now, I think you've also said a really important set of points. One of which is get your patient, get your child, get your family referred to an expert research center there where they will be up to date and the most current thinking on the topic, and also get your child, get your family member referred to a place where they do apheresis. I'm curious, through the pandemic, we're all using virtual technology and telemedicine. Has your world around prevention increased with the use of telemedicine, where people want to see Dr. Baum without being able to get to you?
I would not say it's increased. It remained sort of steady because of the ability to use telemedicine. So people have not been cut off as to the extent that you would have imagined they'd be cut off. But on the other hand, we've seen a lot of data, about people not going to the doctor and having their lipids checked, not going in for an infarct, for chest pain, or going to the doctor. So I think it's been more of a problem rather than improving the aspect of telemedicine. I thought you were going to go to the apheresis question. Did they not show up for apheresis in COVID? But they actually did show up for apheresis. So they understand the importance of apheresis, and they've continued coming for apheresis. It really is a very valuable procedure.
Yeah, that's good to hear, because it's people who have a life-threatening disease, which this clearly is, making sure that they're getting advanced technology is critically important. Yeah, I'd seen a piece of data maybe it was from one of the big national laboratory providers, maybe mid-pandemic, that the ordering of hemoglobin A1C and the ordering of lipid profiles essentially plummeted.
Yes.
Because people saw that as an elective procedure, when in fact, for some people, it's more than elective. It's really potentially a life-saving procedure.
Right. I agree. We've definitely taken a hit on multiple fronts during this pandemic. So hopefully we're coming out of that soon.
Yes. Well, Seth, I want to thank you for joining us here today on Medscape Cardiology. It really has been fun to set the stage for the Getting Back to the Heart of Cardiology conference in December. I'm looking forward to this session on rare cardiovascular diseases. And thank you for giving us a preview on a very rare but incredibly important disorder, homozygous FH or HoFH. So thanks, Dr. Baum, for joining us here on Medscape Cardiology.
Thank you. It's been fun. I appreciate it.